My name is Abdul, one of the neurosurgery trainees, and I'd like to present a case titled A Sylvian Adventure on behalf of Mr. Caird and the Department of Pediatric Neurosurgery at Temple Street. So this is a case of DK, who's a 15-year-old male, initially brought in by ambulance to Sligo General Hospital post a road traffic accident. He has a background history of mild asthma. He was a term delivery, no antenatal medical or surgical history, and no developmental delays in his background. So it was an unclear history and mechanism of injury. He was found unrestrained in the backseat of a car which was static, and there was another vehicle at the side, likely post-collision with the patient's car. The second car was pushed away, and it was not a difficult extrication. There was no collateral history available at the time. So management, according to advanced trauma life support, with a primary survey at the scene and in ED in Sligo, there was airway with cervical spine immobilization. So his GCS was 5 at the scene and he wasn't maintaining his airway. So they did an oropharyngeal airway adjunct at the scene, and he was very agitated in the ED. So a decision was made for rapid sequence intubation. In terms of his breathing, he had decreased chest rise and breath sounds in the left thorax, and a chest x-ray showed a left-sided pneumothorax, and the general surgeons put in a 28 French chest tube for same. In terms of his circulation, he was hemodynamically stable, not requiring any pressors or red cell transfusion. And like I said, his GCS was 5 with a breakdown of E1, V1, and M3. So he's flexing with pupils 2+ bilaterally, and they were reactive. In terms of his exposure environment, he was normothermic, and bleeding, a large amount of bleeding was noted from his head due to a right-sided scalp laceration. Otherwise, there were no external injuries noted on the primary survey. So he was stabilized and he underwent a CT trauma series. So he was a polytrauma case with a lot of injuries, but we're going to focus on the CNS injuries. Essentially, he had a comminuted depressed right calvarial and central skull-base fractures involving the sphenoid sinus and dorsum sella. He had a very minimally displaced right occipital bone fracture as well. And of note, he had a right frontal intraparenchymal hemorrhage with midline shift and evidence of early transtentorial herniation. In addition, he had a diffuse axonal injury, and his other injuries included a displaced right posterior first rib fracture, right midclavicular fracture, and like I said, a left-sided pneumothorax, but there was no flail chest. He also had a significant pelvic fractures with associated hematoma, and he had a distorted and malaligned pubic symphysis. This is his initial CT brain at Sligo. You can see a large subgaleal hematoma and the associated right-sided fracture, depressed skull fracture. You can see the CSF spaces of the basal cisterns are not as open, giving evidence of early transtentorial herniation. And now we can see clearly a right-sided intracerebral hemorrhage with midline shift. Okay, so what did we do? He was transferred across to Temple Street, and he underwent a right frontotemporal decompressive craniectomy and evacuation of the right-sided intracerebral hemorrhage with insertion of ICP. So intra-op, what we found was he had multiple fracture fragments identified when we were elevating the bone flap. There was a puncture wound in the dura, noted over the Sylvian fissure, and the underlying dura was tense. There was an acute subdural hemorrhage was also noted and evacuated, and the brain was quite swollen. And we used an ultrasound to identify the right-sided intracerebral hemorrhage deep to the Sylvian vessels, and with a cortical puncture that was also noted. We achieved a good evacuation, and there was moderate bleeding noted from the laceration to the Sylvian veins, which required some diathermy and direct pressure for hemostasis. And the dura was overlaid but not closed, so we used an expansion duroplasty closure, so we used a pericranial flap, and we inserted an intracranial pressure monitor. So these are some of his images. So you can see pre-op clear Stovein right frontal depressed fracture with bleeding. And this is the fracture exposure. So there were a lot of fracture fragments that we had to go looking for and remove them. So to expose the fracture, and once the fracture was exposed, there's the dura, and you can see we're pointing out a dural puncture site prior to the durotomy. And this is just demonstrating digital tamponading of torrential venous bleeding from the Sylvian veins. And this is demonstrating the use of ultrasound intra-op to localize the intracerebral hemorrhage for evacuation. This is his post-op CT brain. So you can see the CSF spaces are open. Good evacuation of the right-sided intracerebral hematoma that was previously seen. So he was admitted to the pediatric ICU post-op. His ICPs remained less than 20 for 5 days, and we removed the ICP thereafter. He was weaned off sedation and extubated, and he was transferred to the ward level after 9 days of stay in the ICU. So on the ward level, he developed an LRTI, which was treated with tazocin, and we also gave him seizure prophylaxis for a query seizure. He had an episode of tachycardia with eye deviation. He also underwent CT angiogram intracranial to rule any pseudoaneurysms secondary to trauma, and he underwent a custom bone cranioplasty 1 month post-admission. He required extensive MDT input and neurorehabilitation, and he was discharged home after 47 days of inpatient stay. So I just want to talk about a little bit about pediatric traumatic brain injury and its relevance. So 75% of children are hospitalized that are hospitalized for trauma have a head injury, and traumatic brain injury is actually the most common cause of pediatric morbidity and mortality. Overall, the mortality is 10 to 13%, but if they present with decerebrate posturing, so extending on, then the mortality is as high as 71%, which is quite significant. And TBI is the most common cause of intracranial hypertension due to a rise in their intracranial pressures. This is to do with the Monroe-Kelly doctrine. And in turn, the intracranial hypertension is the most common cause of death and disability following a severe TBI. So he did have severe TBI because his GCS is less than 8. And it's an independent risk factor for poor neurological outcome as well. So the question is to decompress or not to decompress, and this is very controversial in the literature. You know, the early decompression within 24 hours is recommended for TBI patients without brainstem dysfunction requiring neurosurgery for removing of intracranial collections, which was the case for our patient. And the present data suggests that complications of TBI may be reduced following early decompression. However, there's a poor quality of survivors, so we might be able to save them, but what's their quality of life going forward? And the literature shows it's not great. So there's lots of indications and contraindications for performing a decompression, and they're usually classified either supratentorial or infratentorial or intraaxial or extraaxial. Essentially, indications for decompression are malignant infarction of the MCA, for which there is good evidence, severe TBI refractory. Severe TBI causing raised ICPs that are refractory to medical management, and cerebral swelling due to subarachnoid hemorrhage for vasospasm or hypertensive bleeds, and severe cerebral venous sinus thrombosis. So in our case, it was refractory ICP, refractory to medical management for severe TBI in the setting of trauma. So how do we perform it? We do a reverse question mark incision involving the zygomatic arch superior to the pinna, extending to the inion, and then medially lateral to the midline, and then anteriorly to the hairline, which is depicted by the green line over here. Incisions that is depicted by the red line should not be used because it can be quite constrictive and lead to herniation. So we make the incision. What we do is then we expose the scalp along the temporalis muscle as a single myocutaneous flap anterior inferiorly, and then we drill frontal, temporal, and parietal burr holes and use a craniotome to take the bone off, and then we perform a stellate gyrotomy, and we get access and we leave the bone off in a craniectomy post-op. So I'm just going to talk a little bit about outcome data for traumatic brain injury and decompression. This is just for trauma. There's other data for different indications of decompression. So there's two really major trials that are randomized control trials. The first is the DECRA trial, in which there's 155 patients who compared bifrontotemporal parietal decompressive craniectomy with standard medical therapy in the setting of TBI. And it showed that decompression in the decompression group, there was less raised ICPs, fewer interventions, shorter ICU stays, but they had worse functional outcome at 6 months, and the mortality was actually similar between the two groups. And the worst functional outcomes are due to complications such as, you know, the craniectomy allowed expansion of the swollen brain, which may lead to axonal stretch and neural injury. There's issues with cerebral blood flow and metabolism. And it's also, they did a bifrontotemporal parotid which can be, which is associated with more complications. So it's not really relevant to the hemicraniectomy that's most commonly done. And there's also complications associated with cranioplasties going forward. The other trial is the Rescue ICP trial, in which there were 408 patients, and they measured the effect that decompression had on mortality outcomes 6 months after TBI, and it showed that mortality was actually 22% lower in those who underwent decompression versus medical management. However, the decompressive patients had a higher morbidity rate. What that means is they survived, but they survived in a vegetative state or with severe disability. And you know, the proportion of patients with a good outcome was actually comparable between the two study arms. So just to you know, finish up, I suppose I want to talk a little bit about the neurorehabilitation in pediatrics following the TBI, because I just wonder how it's set up, what's the system, what's the structure, what are its shortcomings, and what needs to be done in the future. Because yes, a decompression requires great skill, planning, and execution. And then once we do it, they're linked in with the rehab team, and then we kind of forget about it, and we don't really know that much about it. But you know, the actual real benefits with regards to functional outcomes after a TBI are actually, a large part of it is associated, is associated with how good the rehab is. And you know, the quality of life that the patient will have is a large part of your decision-making process when you're going to decide to decompress the patient. Based and also other factors are involved. So it's quite an important thing to know about, I suppose. So, you know, the provision of rehabilitation is the mainstay of treatment for young people following TBI. There's an acute phase, a subacute phase, and a chronic phase. And only 1% of children involved in major trauma are discharged directly to a specialist rehabilitation. 83% are discharged directly home. This is in contrast to our adult population, you know, and it's due to resources, really. So in adults, what we usually, if you've worked in both sides, you'll see that adults after TBI go to convalescence, or they go to a rehab facility before going home. But most pediatric patients go directly home, that's because there's no standardized pathway, and it's always due to resources and its capacity and funding issues. So, you know, there's a significant burden of cognitive, behavioral, and mental health difficulties in young people who experience even mild to moderate TBI, never mind severe TBI. And it's not just about physical disability. And these cognitive and behavioral and mental health issues become apparent long after the injury. And it's due to these kids fail to keep pace with social and educational and environmental demands. And this is because they need a specific type of therapy, and it's known that they need a specific type of therapy from other causes of disability. And you know, the needs of children with TBI are often overlooked in the design of services. What I mean by that is, so for example, in this case, yes, he'll be discharged and he'll be seen by a neurorehabilitation OPD, but that's only a medical assessment. There's no therapy available in that OPD, and he'll be referred to the NRH, the waiting list for which is 6 months. And sometimes you need to fit a certain criteria to be seen by the NRH. You need one medical assessment and you need 2 therapy needs. So if someone comes in with TBI, but they only have 1 therapy need, such as physio or occupational, then their referral gets rejected, which is really detrimental to their rehab going forward. It really is a limiting factor. And like I said, the waiting list is 6 months. So, you know, and that's not good enough, because there's recovery following TBI follows a sigmoidal pattern. There's a period of rapid recovery, then slowing, and then eventually it plateaus. And there's a very specific window for recovery that you need to get them into and work on them for them to have good functional outcomes going forward. And we miss that by having a 6-month waiting list, essentially. You know, neuroplasticity is not inherently good, and it must be harnessed by practice of meaningful tasks to improve recovery. So rehab is quite intricate. It's more complicated than just physical rehab. These kids need a certain amount of MDT with specialized skills to perform meaningful tasks to improve their recovery going forward, and that sometimes is overlooked. So I suppose the key points from the talk is long-term data for decompressive craniectomy is lacking, and we're still awaiting big high-quality trials. They may produce more survivors, but you have to look at the quality of life as well. They may produce survivors with severe disability. But decompression is associated with better outcomes in pediatric population with severe TBI, and that's because kids usually bounce back really better than adults do. but the optimal timing is still uncertain. It's not to be routinely used in TBI, but it appears equipoise because you need to balance it, and clinical practice is kind of already changed. But really, the pediatric rehabilitation services in Ireland are in urgent need of review and expansion. And the way we can improve on them is we can have more inpatient services where the guys can come in and get seen and get their rehab and go home, and come back. But also you need a lot of staffing for that and a lot of funding for that. And we can also have more community services that are covered by NRH. So you don't just have to go to the NRH. You could have NRH personnel that could be based around the country and do these community services. But again, you need funding, but it is justified and it needs to be looked into further. So this is just with consent for the patient. So it's good to see that he came in with a GCS of 5 and he walked out with his parents. So it's just really good to see that. And he was one of the lucky few who had a good outcome, but it's still yet to be determined how he will do going forward, because he fits into this certain population of kids that are likely to do bad with social and environmental needs after TBI, especially with the type of groups that they're involved in. But it was good to see this, and that's all. Thank you very much.
Thanks very much, Abdu. Very nice presentation of a pretty complicated case. Just going back in terms of the case itself and the neurosurgical aspects of it, what you did mention, kind of the hematoma being kind of perisylvian. There was no vascular injury, am I right?
No, not from the arteries, but there was some torrential bleeding from the veins, which we controlled externally with just digital tamponading and diathermy use. Yeah.
Very good. And the rest of his injuries didn't need much in the way of intervention, did they?
No, so orthopedics saw him for that quite significant pelvic hematoma and malaligned pubic symphysis. So he had a pelvic binder on, but it was it was conservative management, and he was allowed to mobilize slowly. Weight bear 15% 1 week, 20% the week after, and it was conservatively managed. Yeah.
Well, I think it's a very nice case. It really demonstrates, again, like some of the other cases that have been presented here, and the kind of degree of multidisciplinary team that needs to be involved. And again, we see that the head injury really determines kind of the speed at which things need to be done, and also the kind of final outcome is, as with many of the trauma patients, is what determines the outcome. I thought it was interesting that you said that those kids with decerebrate, who are decerebrate at the time of presentation, have a 70% mortality. I mean, I must say, I thought maybe in kids it would be a bit less.
Better.
Yeah, because we always kind of view the kids as doing a lot better, but it still shows if you're, I suppose, decerebrate posturing at the end of the day, usually it indicates some degree of brainstem dysfunction, which is probably why they're having such a bad outcome. You mentioned the 2 trials, the DECRA and Rescue ICP. Wasn't there one? There wasn't one. If anybody knows any of the pediatric guys, especially, there wasn't one purely on pediatrics, was there?
I'm unsure, Prof.
Pediatric TBI.
The ones that I looked up, these were the ones that came up.
Or it may be that one of them included the pediatric population, but yeah, and maybe at one of our next sessions we need to show on the Rescue ICP that you showed the results. They actually quite nicely have the Glasgow outcome score, and you can see that a certain percentage they survive with fairly good quality of life, but as you said, you also increase the number who survive with poor quality of life.
Yeah.
So you're right in that. I can't see any other questions or comments. If anybody has any burning questions, put them up. I thought your point about rehab was really, really good. For as long as I can remember, we've been saying that rehab services in Ireland are extremely poorly provided, as in terms of capacity. Of course, the consultants and the nurses and the people who work in rehab work extremely hard and provide an amazing service for us and the patients, but it's just don't have enough beds and enough capacity, which has a a negative impact, as you know, on our beds of patients waiting, and it's not good. Okay, if that's good, thanks very much, Abdu, with a great presentation. And the next presentation is by Ms. Catherine Moran and Mr. Jack Horan, and it's about central cord syndrome. Am I right?
So this is a case of central cord syndrome and management. So this is a 71-year-old gentleman with no past medical history of note. He was at his granddaughter's birthday party the day prior to his admission and was last seen well at 10 p.m. Of note, he did have some alcohol on board. At 6 a.m., he was found by his wife on the ground at home. He had no recollection of the events that led to him being on the ground, and he couldn't get up. He presented to his referring hospital with acute weakness of his upper and lower limbs and upper limb paresthesias. His initial vitals, his heart rate was 65, his blood pressure was 76/45, giving a MAP of 55, and his GCS was 15. His initial examination, he had both upper and lower limb weakness. So in most myotomes in his upper limb and lower limb, he had 2 out of 5 power. So he had, of note, he had 0 out of 5 power in C8 and T1 bilaterally. His sensation was also reduced in C6 down to T1 bilaterally. His reflexes were normal, and his deep anal pressure and voluntary anal contraction were intact. So this would give him an ASIA score of C. So I'll just go through the ASIA scoring. So ASIA scoring of A is a complete injury. So there's no sensory or motor function is preserved below the level of the injury. ASIA B is then sensory incomplete. So sensory but not motor function is preserved below the neurological level. And then coming on to ASIA C, so motor incomplete, motor function is preserved below the neurological level, but half of the key muscle functions are a grade 3 of less than 3, so either 0 to 2. ASIA D, then motor incomplete, so motor function is preserved below the neurological level, and at least half or more than half of the key muscle functions have a muscle grading score of 3 and above. And ASIA E then is a normal examination. So this is the ASIA score, which I'm sure a lot of people are familiar with. So the essentially the examination, you get a score. So the upper and lower limb myotomes add up to a score of so 25 for the upper limb and 25 for the lower limb, and they're added together, and you get 100 total then for your motor score. So the elbow flexors, so C5 then is your elbow flexors, C6 is your wrist extensors, C7 is your elbow extensors, C8 is finger flexors, and T1 is your finger abductors. And then for the lower limb, hip flexors are L2, L3 is knee extensors, L4 is ankle dorsiflexors, L5 is long toe extensors, and S1 is ankle plantar flexors. So this, based on this gentleman's initial presentation, he had an ASIA score of C. His initial management then, so he was managed with an ABCDE approach. He had fluid resuscitation with 2 liters of normal saline. A central line was inserted and a noradrenaline infusion was started. So his BP then came up to 126/57, giving him a MAP of 80. Of note, the CT of his cervical spine had no acute fracture dislocation, and his CT brain was also normal. He was then transferred to Beaumont Hospital for an urgent MRI scan. So this here is a video of his initial MRI of his cervical spine. So it's both a sagittal and axial. So he has some acute or acute on chronic left paracentral disc and osteophyte complex at C4-5 causing severe canal stenosis. There's also focal acute traumatic induced spinal cord edema at C4-5. So he underwent a C4-5 ACDF less than 24 hours after his admission. So platysma was incised, the carotid sheath was identified and retracted laterally, the esophagia and trachea and larynx were retracted medially, the longus coli was identified and undermined, the microscope was brought in, and the disc space was drilled down, the PLL was opened, and then the cage was put in. These were some post-operative, so an AP and lateral of his cervical spine after the operation. And then this is a post-operative MRI performed 5 days after the operation. So on this scan, you can see that the canal stenosis has improved, but the contusion has blossomed on this scan compared to his preoperative scan. Post-operative recovery, he was in ICU for a period of time, so he was on noradrenaline for 7 days to maintain a mean arterial pressure of greater than 85. He had high-dose dexamethasone for 3 days. He had intensive physiotherapy that it involved, initially he was bedbound and progressed to standing with aids 2 weeks post-operatively. He was seen by neuropsychology. Now he's mobilizing with a rollator Zimmer frame, and the dexterity in his hands has improved. He's using hand exercise devices. However, he's unable to hold objects such as a cup, so he can use an adapted spoon. He has normal bladder function, and he had a delayed recurrent laryngeal nerve palsy 10 days post-op, and he's due to be followed up with our ENT colleagues for this. His current examination then, so in C5 bilaterally is 5 out of 5, C6 is 4 out of 5, C7 is 5 out of 5, and C8 and T1 is 3 out of 5. His sensation has all but come back in his upper limbs, apart from left C7 is still diminished. His lower limb motor score has improved, so L2 is 5 out of 5 bilaterally, L3 to L5 is 4 out of 5 bilaterally, and S1 is 5 out of 5, and his sensation is intact in his lower limbs. So currently his neurological status, he's improved to a scoring of Asia D. And Miss Warren is now going to go through the discussion on central cord syndrome.
That's great, Jack. Thank you. So basically, we're going to talk a little bit about this topic, and it's pretty relevant due to an elderly population, because that's who you tend to see this injury in. It tends to be in the bracket of a fragility injury. So what it actually is traumatic central cord syndrome in a spondylitic spine. So somebody who has pre-accident degenerative disease of the spine with anterior osteophytes or small disc prolapses and posterior ligamentum flavum hypertrophy will be at risk of one of these types of injuries. And what does it affect? So there's a particular neurological deficit that you get with this type of an injury. And the reason you get this type of deficit is because it involves the center of the cord. So as you can see here, your ascending or dorsal columns at the back are rather large, and they don't tend to be that affected. What is mostly affected is the medial portion of the lateral corticospinal tract here, and in that portion is the hand, which is quite central, and also the anterior corticospinal tract here, again centrally. But the spinothalamic tracts tend to be a little bit more on the outer rim of the cord. So that's why the sensation in this gentleman was diminished but not completely gone. And you tend to get, as I said, more upper limb dysfunction and a motor dysfunction. So you get motor more than sensory, upper limbs more than lower limbs, and a distal problem more than a proximal problem. And that's basically due to the architecture of the actual cord itself. So central cord syndrome is actually the most common type of an incomplete spinal cord injury, and there's about 11,000 cases per year in the US. It was described first in the 50s by Schneider. And as I said, it's an injury of frailty, which tends to occur in older people. It obviously can occur in younger people who have underlying cervical spondylosis. And the mechanism of injury is usually a hyperextension injury, which is what this gentleman had when he thinks he fell forward and hit his forehead. And these injuries can be relatively minor and low impact injuries. So it can be a simple fall at home, which is what he had. And what it does, it presents as a spectrum. You can have weakness limited to the hands and forearms with just sensory preservation. As in this gentleman, he had weakness in both upper and lower limbs, and it can go all the way to a complete quadriparesis, with the sacrosparium being the only evidence of an incomplete spinal cord injury. Recovery occurs, but it's often incomplete. And early surgical treatment of central cord syndrome remains controversial, and that's because of its natural history of the disease. So more precise term for the condition is acute traumatic myelopathy. So it's acute cervical cord injury in the setting of a stable spine with either congenital or degenerative stenosis, which are i.e. anterior osteophytes, posterior ligamentum hypertrophy. Historically, it's been treated non-surgically. The optimum treatment remains controversial. And as I said, it has generally a favorable outcome, but poor hand recovery in this type of injury. So the medical management is something that was initiated early in this gentleman. When he was initially referred from his referring hospital, they had instituted the most important part of care, really, which is blood pressure targets. So in acute spinal cord injury, medical management has become the mainstay of treatment alongside surgical intervention in improving outcomes. Early augmentation of mean arterial blood pressure, or MAP, intensive care management, which he also had, and prevention of secondary complications during a patient's hospital course is vital. So avoidance of hypotension. So we saw that this gentleman on initial arrival to A&E at the referring hospital was hypotensive, secondary to spinal shock, and he was immediately treated with noradrenaline and an arterial line to monitor this. So in patients with this type of injury, you have to strictly adhere to blood pressure targets to maintain adequate cerebral perfusion pressure and prevent secondary neuronal injury. And the guidance from the American Association of Neurological Surgeons is that our MAP targets should be 85 to 90, and that should be for 7 days following the initial injury. And this is probably one of the most important things that was done in this gentleman's case, was that he had early MAP goals instituted. So regards to surgery, the management controversies with this is, so when associated with a fracture or dislocation, reduction and decompression are long established goals of treatment of cervical spine injury. But in the case of central cord syndrome, you don't have a fracture or instability, and you have a therapeutic dilemma related to the role of surgical decompression in the absence of instability. A common approach to treating these patients is to rule out instability and then observe the patient's neurological recovery until they achieved a neurological plateau, and then consider surgical decompression at 6 weeks or longer. And this was the traditional way that these injuries were managed, and this has slowly changed over the last 20 years. And why? One of the concerns is that it does have a favorable prognosis, and the patients tend to start to recover without intervention. And they may have already recovered to some degree when they reach the acute treatment center. Another problem is often that if the canal stenosis is long and they cover many levels, whether or not you're going to go in and do a decompression on an acutely swollen spine, which will be worse usually at 72 hours. So if you're going to do something, you basically do it early within 24 hours, but the 72-hour period is where your spinal cord swelling will be worse. So we'd avoid doing something at that stage. So basically there's a risk in recommending urgent surgical decompression to a patient who is spontaneously recovering. And now this gentleman was not spontaneously recovering. He was fluctuating a little bit pre-op in terms of his lower limb neurological status. But the sole reason for doing so is to accelerate the rate of recovery or improve the final neurological function. And then for surgery, there's different types of surgery. This gentleman had a single level problem in his preoperative MRI scan. His he underwent an anterior cervical discectomy, but for a longer injury, if you like, if there's a longer spondylosis or stenosis of the cervical cord, either a cervical laminectomy, which is a posterior cervical decompression, or as a posterior cervical decompression infusion with lateral mass screws, which is what is at the bottom right-hand corner. So a group from Johns Hopkins looked at their whole US database from 2003 to 2010 to examine the trends in management of these patients. So they looked at a total of over 16,000 patients who had been admitted with central cord syndrome. So it is a common incomplete type of spinal cord injury. So they found that a total of only 39% underwent surgery at all. 74% of the entire cohort were male, so it tends to be male group. Mean age was 58.9, which was maybe a bit younger than you would have anticipated. So 60.6% were managed conservatively. And the most common surgery that they had was an ACDF. And overall, in the years going from 2003 to 2010, surgical management increased by an average of 40% per year. So more people were getting an earlier decompression. And overall, inpatient mortality of these cohorts were 2.6%. And elderly patients with medical comorbidities were associated with lower surgical rates. So that looked at generally what had been happening. And then surgical timing in acute spinal cord injury was published in 2021. This demonstrated some benefits in early decompression, less than 24 hours versus late decompression. It didn't, however, include a non-operative cohort. But overall, the ethos has been changing to an earlier intervention. And I think probably it's their ASIA score that determines whether or not, and I'll look at another study later, their initial ASIA score, whether or not they should have that early intervention or whether or not it would be of benefit to them. So recent systemic review expert opinion noted that 46% of surgeons would operate on an ASIA D, so that's somebody with a better neurological status, and 63% would operate on an ASIA C. So Failing's group from Canada looked again at specifically early versus late surgical decompression. And they did this using the similar cohort that was looked at in the previous paper. So they looked at 16,000 patients, but they did a propensity score matching randomization to early and late. And this basically reduces confounders in the confounders in the group. And they had 93 early surgery patients and 93 late surgery patients, which was greater than 24 hours. And what they found was patients who they were propensity score matched cohort studies. So instead of a randomized control trial, it was looking at previous data, but using this technique to give a more accurate difference between the two groups. And their primary endpoint was recovery in upper extremity motor function and lower extremity motor function at 1 year. And this is a look at the numbers at their baseline. So you can see that their early surgery, they were scoring 25 out of 50 in their preoperative ASIA score and 39 in their lower. So the upper extremities were more affected neurologically than their lower limbs, which we know from this type of injury. And then their motor functional recovery. So there was a statistical significance in early surgery for the upper limb function. The lower limb function tended to improve regardless of surgery. And you can see the post-operative or the 1 year results there of lower limb function going from 47.6 to 46.2 with a max obviously of 50. And you can see here that basically where the difference was in somebody with an ASIA score of C rather than D. So somebody with a worse initial neurological picture got a better improvement and a statistically significant improvement in their upper limb function post-operatively. That was not seen in the upper limbs in a less severe case of the ASIA D scores. So it was 186 patients, 93 early surgeries. Again, their mean age was a little lower. It was 47.8 than you would expect. So early decompression resulted in improved upper limb function, but not lower limb function. And the outcomes were comparable with the ASIA D, but they were greater recovery in upper limb function with ASIA C. So overall, it does have a good prognosis, but full functional recovery as well. And it's usually the hands that remain a problem, which is, as is the case with our patient. They're usually ambulatory at final follow-up, and hand recovery is unpredictable, and they may have permanent clumsy hands. And the recovery usually occurs in a typical pattern with the lower extremities first, then bladder and bowel function, then proximal upper extremity, and then the hand function tends to be last to recover. And that's where the rehabilitation is focused on. And thank you.
That's a fantastic presentation, Catherine. And Jack, thanks very much. Really covered it really well. So just to go back, the patient was transferred from another hospital to Beaumont, and you, in this case, you operated early, effectively. Did I get that right?
Had surgery within 24 hours of admission here, which was a little longer than his, so it was probably about 36 hours post his actual injury.
Right. And just obviously you mentioned the blood pressure control being extremely important in the initial hours and days, and up to 7 days you want to keep a map above 85 to 90. In A&E, if SHO is called down to see one of these, should they put them in a collar or not? And if so, what type of collar?
With this patient is yes, there's nothing wrong with putting anybody in a collar. We can always, and we've kept him in a collar more for comfort for some weeks afterwards. So yes, put them in a collar, because really what you want to see anyway pre the MRI scan is stir sequences, to see if there's any posterior ligamentous complex injury. He had a little bit of high signal in his MRI scan, but the main basically point of management with his care was that he was immediately seen by an anaesthetist. And what prompted it, I guess, was that he had a low MAP to start with. So it was kind of flagged more so maybe than it would have been had he had a low normal BP. So he was hypotensive, but not saying that that's the case, but that that was immediately dealt with. And he was, when he arrived here, he was on a noradrenaline infusion with MAPs greater than 85. That's so he'd been instituted since A&E.
That's good management by the local hospital.
Yeah.
And I'm just going to ask some really old-fashioned questions, like is methylprednisolone is out, never use it?
It's out, but we still use it. There's no evidence.
I just saw this one, I think, went on Dex. Am I right?
Yeah, and again, he had a shot of it before we came, and we continued on.
Right. Okay.
But there isn't any evidence.
There's no good evidence for it. Very good. And then anterior versus posterior approach, is it always anterior for a case like this? Pretty much?
Yeah, I tend to, again, if it's multi-level, it'll have to be posterior because you need to do a longer decompression. But when it's kind of focal, like his problem was at C4-5, then an anterior is, I think, a little bit preferable from positioning on the table. So you can keep them a little bit more neutral than nicely flexed for a, and it's obviously the recovery from it is easier from an anterior approach because it's less painful.
And I think you mentioned something about this, but I'm not sure if I got it. Fusion versus no fusion, or did you say if it's multi-level, then you were putting it?
Again, it depends on usually the institute, but this is by definition a stable spinal problem, which is a problem of stenosis. So either is fine.
Yeah. Nick has his hands up. Did you want to ask a question, Nick?
Yes, hi. Thank you very much. Really nice talk. Thank you both. I really enjoyed it. It's not so much of a question, it's more of a comment, really. The first thing is we should never forget with spinal cord injuries the neurogenic shock. So it's something we don't think too much about it, but actually it's a very important thing, and many times we don't think about it. So we had a series of central cord syndromes in Leeds, and the one thing we were very aggressive was to get those patients on inotropes at an early stage, and we did see that they did better. So MAP, as Catherine kind of hinted very strongly, is vital. So that's one thing I wanted to mention. The other thing, since the discussion came about steroids and the spinal cord injury, this ongoing, painful, most of the times unpleasant debates. So there's no strong evidence to suggest to use them. But interestingly, NICE guidelines do leave an open door for the use of them, but it's very kind of discretional. I've never used it, and very few people I know that I work with in Nottingham or Leeds use them. So that's my take on it. So I'm very reluctant.
Very good, very good.
Thank you very much for
very
the
good.
talk. Thank you.
No,
Thank
I
you so
think
much.
they're good comments, Nick. Thanks very much. The other thing I just noticed when you were saying the lower limb in that trial that you were, not a trial, but the propensity match one, the lower limbs improved anyway. The upper limb seemed to improve with surgery. I presume that's to do with that anatomy that you showed at the beginning, because the compression is central. And you're removing that compression, so that's mainly off the hand and arm, upper limb bit of your corticospinal tract. Yeah, no, that's very good. I think that's excellent. Can MRI replace CT in the diagnosis? Somebody asks.
No, anytime you're looking at a fracture, you want to be looking at bony windows and a CT. So once the fractures are ruled, so I guess the reason that you would do a really quick MRI scan is somebody in elderly, is the other main differential is that, especially if they're on anticoagulants, is that they have a hematoma. So an epidural spinal hematoma that's something that there is no clinical equipoise about whether or not that needs decompression. So that needs immediate evacuation. The point of this is that the injury is sustained as you extend onto the osteophytes, and that there's not a new compression that wasn't there. And that's the question, whether or not you should go in. And if you do a vox pop among spinal surgeons in Dublin, which I did recently, and said, do you do them earlier, or do you do them late? And because it's still a debate. And a lot of people would say, if they're getting better, I'm not going to go in there with a surgery and a rongeur. And because by definition, in order to release the spine, you have to get a punch in there, and it's going to be at least 1 millimeter for some time with pressure on it. So, but the other one, as I said, the reason we need an MRI scan in somebody with a normal CT, I'd always do a CT scan first, is looking for a hematoma, especially an elderly person with anticoagulants. So
you need both CT and MRI.
This is given to you on a CT.
Say again?
Unless the diagnosis is given to you on a CT.
Okay. CT first and then decide on MRI, effectively.
Yeah.
Very good. I think we're going to see more and more of these things, isn't it? Elderly people, more elderly people means more falls, and more falls means more of these types of injuries. So
yeah, and at our recent Irish Spine Society, this was a main topic, because basically it was frailty injuries, and this kind of goes under that heading. And yeah, it's and it, as I said, it's small. It's a small minor trauma of tripping in the garden and just falling in a certain hyperextension way.
So we'll be talking about subdural hematomas and central cord syndrome for a long time to come. Thanks very much, everybody. Abdu, Jack, and Catherine, brilliant presentations, and thank you very much. Really, really good reviews of the literature as well.